Welcome to the Explainer. Okay, so if you're working in a microbiology lab, the name Actinomyces odontolyticus probably rings a bell, right? Well, what if I told you that name is basically obsolete? Today, we're diving deep into its new identity, Schaalia odontolytica, and why this is so much more than just a simple name change.
So, what's the deal with the switch? This wasn't just some committee deciding to shake things up. The 2018 reclassification was a big deal, driven by whole genome sequencing. What the data showed was that there were some really significant deep-seated differences separating this organism from the true Actinomyces species, like Actinomyces israeli.
And that brings us to the big question, the so what, for all of us in the lab. Why should you care about this name change? Well, as we're about to see, it has direct practical implications for the accuracy of our databases, our diagnostic methods, and even how we find the latest research on this bug. To get you the most up-to-date profile on this pathogen, we used a Gemini deep search to synthesize information from a whole host of research papers. It's a powerful way to get the full picture. And if you want to geek out on the primary literature yourself, the full list of sources is right there for you in the linked notebook document.
Right. Let's roll up our sleeves and get to the bench work. What does Schaalia odontolytica actually look like, and how does it behave in the lab?
So you get it under the microscope, and the first thing you'll notice is its pleomorphic nature. You're looking for those classic gram-positive rods, often in those diphtheroid or Chinese letter shapes. It's a facultative anaerobe, so it really prefers life without oxygen. And you're gonna need some patience. It's a slow grower. You're looking at 5 to 7 days before you see its most telling feature.
And that feature is this fantastic rust-brown to red pigment it produces on blood agar. Here's a really cool bench-side tip. That color actually gets stronger and intensifies after you expose the plate to air. It's a huge diagnostic flag, and a very specific one at that. For some beautiful pictures of this, you should definitely check out MicroCanvas.
All right, let's look at its biochemical fingerprint. Being catalase negative is super helpful for separating it from corny bacterium, but the real key player here is nitrate reduction. It's positive, and that's a crucial way to tell it apart from Actinomyces israeli. You see, these simple tests are still incredibly powerful.
Now, this is where it gets really weird and cool. It turns out Schaalia odontolytica is a host for an even smaller bacterium, this tiny little epiparasite called Saccharibacteria TM7x. This thing literally lives on the surface of Schaalia and cannot survive by itself. And this isn't just a fun fact. This relationship can actually alter the virulence of Schaalia, possibly helping it invade new parts of the body.
So what kind of trouble does this organism cause in patients?
Well, Schaalia odontolytica is a true master of disguise. It causes these chronic, slow-burning infections that are so often mistaken for something else completely.
It's the textbook cause of lumpy jaw, sure, but it can also cause lung infections that look identical to tuberculosis or even lung cancer on a scan. In the pelvis, it has a famous link with long-term IUD use, where it can create masses that look scarily like ovarian cancer. The absolute hallmark of these infections is this intense, hard, woody fibrosis, and, if you're lucky, finding those macroscopic sulfur granules in the pus. That's a critical clue for the surgeon and the lab.
Okay, so we know it's a slow grower, which is a pain. How do we get a faster, more precise ID in a modern lab? Let's talk strategy.
MALDI-TOF has, of course, been a total game changer, and it works really well for Schaalia odontolytica. But, and this is a big but, you've got to watch out for a couple of traps. First, your database has to be up to date. If it isn't, it might still spit out the old name, Actinomyces. Second, it can sometimes have a tough time telling it apart from its very close relative Schaalia mare, which can be a more aggressive bug.
So here is your pro tip for the bench to get around that. To get a really solid, high-confidence score pretty much every time, use a formic acid extraction. Schaalia has a thick gram-positive cell wall, which can be tough for the MALDI to break through. This super simple on-plate method helps dissolve that wall, giving you a much cleaner spectrum and a more trustworthy ID. But when the stakes are high, we're talking an isolate from blood, a prosthetic joint, or the central nervous system, or if that MALDI-TOF result just looks a bit iffy, 16S rRNA sequencing is still the undisputed gold standard. It gives you a definitive, no questions asked identification.
Okay, so we've nailed the ID. Our job isn't done, right? Now we have a crucial role in helping to guide the treatment. So what's the game plan?
The treatment playbook for Schaalia is built on one core principle, and you need to burn this into your memory. high doses for long duration. And the reason is that the antibiotic has to fight its way into that dense, woody, avascular tissue we talked about earlier.
Okay, everybody lean in. If you take away only one single thing from this entire explainer, please make it this. Schaalia odontolytica is intrinsically 100% universally resistant to metronidazole. This means any empirical treatment for a suspected anaerobic infection that relies only on metronidazole is guaranteed to fail. This is probably the most critical stewardship message you can deliver to your clinical teams.
Now, if we look at the latest EUCAS breakpoints, check out the values for benzylpenicillin. That gap between susceptible and resistant is razor thin, just one dilution. This just goes to show how exquisitely sensitive this organism usually is. Its MICs are typically rock bottom low, which makes penicillin the absolute drug of choice.
So what does high-dose, long-duration actually look like in practice? Well, the Dutch SWAB guidelines are a great example. They recommend a massive IV induction dose of benzylpenicillin. We're talking 10 to 20 million units a day for adults. That's followed by a long oral step-down with amoxicillin that can last for 6 to 12 months. And notice the pediatric doses are just as aggressive, calculated to get that deep tissue penetration.
All right, let's bring it all home with a few final crucial points on safety and the key messages to take back to your lab and your teams. Good news on the infection control front. This is pretty straightforward. Schaalia odontolytica is an endogenous pathogen. That means infections come from the patient's own normal flora. There's no risk of person-to-person transmission, so standard precautions are all you need. No special isolation required.
So here's your 3-point cheat sheet. First, taxonomy matters. Use the name Staphylomycia and make sure your MALDI databases are current. Second, your mental shortcut should be think red and resistant. Look for that unique pigment on the plate and never, ever forget its resistance to metronidazole. And finally, be an advocate. Use your expertise to guide clinicians toward the right therapy. High-dose beta-lactams for a long, long time.
And that leaves us with a final thought to chew on. As we learn more about this organism's complex life inside biofilms and its incredibly strange partnership with its own personal parasite, TM7x, how is that going to change our strategies for tackling these incredibly stubborn infections in the years to come?
And that's our deep dive into Schaalia odontolytica. I really hope you found this practical update useful. If you did, please subscribe for more explainers on key bugs and topics in microbiology. Your expertise is valuable to us, so please share your own experiences and questions down in the comments below. Thanks for watching.